Question 1. A 45-year-old patient presents with chronic heartburn, regurgitation, and difficulty swallowing after undergoing a diagnostic upper gastrointestinal endoscopy aid. The findings show mucosal damage in the esophagus and the presence of a sliding hiatal hernia. Which of the following is the most likely diagnosis and appropriate first-line treatment? A. Esophageal varices, beta blockers. B. Gastroesophageal reflux disease, GERD, proton pump inhibitors, PPIs. C. Achalasia, calcium channel blockers. D. Peptic ulcer disease, antibiotics. Answer: B. Gastroesophageal reflux disease, GERD, proton pump inhibitors, PPIs. Explanation: the patient's symptoms of chronic heartburn, regurgitation, and difficulty swallowing, combined with the EGG findings of mucosal damage and sliding hiatal hernia, strongly suggest GERD. GERD is caused by the reflux of stomach contents into the esophagus, often due to malfunctioning lower esophageal sphincter, less or hiatal hernia. The effective first-line treatment for GERD is proton pump inhibitors, PPIs, which reduce gastric acid production and promote mucosal healing. Option: esophageal varices is unlikely based on the patient's lack of risk factors for liver disease or portal hypertension, and varices typically present with signs of acute gastrointestinal bleeding. Option C, achalasia, is motility disorder of the esophagus, which would present with progressive dysphagia and no mucosal damage on endoscopy. Option D, peptic ulcer disease, typically involves epigastric pain and is diagnosed via biopsy or endoscopic findings of ulcers, not mucosal damage consistent with GERD. Question 2. Mr. Davis is a 62-year-old patient with a history of cirrhosis and has been hospitalized for the past week due to hepatic encephalopathy. He is confused, lethargic, and has asterixis. The lab results show elevated ammonia levels. What is the most appropriate next step in management to address his condition? A. Administer intravenous antibiotics to treat potential spontaneous bacterial peritonitis (SBP). B. Initiate lactulose therapy to lower ammonia levels. C. Perform an endoscopic varosal ligation procedure. D. Begin diuretic therapy for fluid retention. Answer: B. Initiate lactulose therapy to lower ammonia levels. Explanation: hepatic encephalopathy is a complication of liver cirrhosis often exacerbated by elevated ammonia levels. Lactulose, a non-absorbable disaccharide, is used to reduce ammonia levels by trapping ammonia in the colon and preventing its absorption. This is the first-line treatment for hepatic encephalopathy and is essential for improving the patient's neurologic status. Option: administer intravenous antibiotics for SBP would be appropriate if the patient showed signs of infection such as fever or ascites, but there is no clear indication of an infection in this case. Option C, endoscopic varosal ligation, is indicated for esophageal varices, but the patient's confusion and elevated ammonia levels point to heat, not varosal bleeding. Option D, begin diuretic therapy, might be considered for managing ascites, but it is not the immediate concern for managing hepatic encephalopathy. Question 3. A 50-year-old female with a history of irritable bowel syndrome (IBS) presents to the clinic complaining of frequent abdominal cramping, bloating, and diarrhea. She has been experiencing increased stress at work. Upon further questioning, she reports that her symptoms worsen during stressful events and improve after bowel movements. Which dietary modification is most likely to provide relief for her condition? A. Gluten-free diet. B. Low FODMAP diet. C. Low-fat diet. D. High-fiber diet. Answer: B. Low FODMAP diet. Explanation: the patient's symptoms, including abdominal cramping, bloating, and diarrhea that worsen with stress and improve after bowel movements, are consistent with IBS. Low FODMAP diet, which involves the elimination of certain fermentable carbohydrates that can exacerbate IBS symptoms, is often recommended to alleviate symptoms. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which can ferment in the gut and cause bloating, gas, and discomfort in individuals with IBS. Option: gluten-free diet, is specifically indicated for celiac disease or gluten intolerance, but there is no indication in this case that the patient has gluten-related disorder. Option C, low-fat diet, may help with certain gastrointestinal conditions such as gallbladder disease or pancreatitis, but is not the primary recommendation for IBS management. Option D, high-fiber diet, may help with constipation-predominant IBS, but can sometimes worsen symptoms like diarrhea and bloating in individuals with IBS. The low FODMAP diet is more targeted approach. Question 4. A 60-year-old male with a history of chronic alcohol use presents with jaundice, fatigue, and abdominal swelling. Laboratory results show elevated liver enzymes, bilirubin levels, and a prolonged prothrombin time. An ultrasound reveals hepatobiliary ascites. What is the most likely diagnosis and what is the first-line treatment? A. Acute hepatitis. Antiviral therapy. B. Cirrhosis and management of ascites and abstinence from alcohol. C. Pancreatitis, pain management and hydration. D. Hepatitis C, direct-acting antiviral agents. Answer: B. Cirrhosis and management of ascites and abstinence from alcohol. Explanation: the patient's presentation of jaundice, fatigue, abdominal swelling, ascites, elevated liver enzymes, bilirubin, and prolonged prothrombin time strongly suggests cirrhosis, a late-stage liver disease often caused by chronic alcohol use. Cirrhosis results in the scarring of liver tissue and can lead to complications such as ascites, jaundice, and coagula. Prolonged PT. The primary management approach includes managing ascites with diuretics, dietary sodium restriction, and abstinence from alcohol to prevent further liver damage. Optional acute hepatitis is less likely, as the symptoms and lab results point to chronic liver disease rather than an acute infection. Option C, pancreatitis, would present with acute epigastric pain, nausea, and vomiting, along with elevated pancreatic enzymes amylase and lipase, which are not mentioned in this case. Option D, hepatitis C, could also cause liver dysfunction, but the chronicity and alcohol history are more indicative of cirrhosis. Question 5. A 48-year-old female with a history of peptic ulcer disease, PUD, presents with upper abdominal pain, nausea, and bloating. She recently tested positive for Helicobacter pylori. Which of the following regimens is considered the most effective for eradicating H. pylori and healing the ulcer? A. Triple therapy with a proton pump inhibitor, PPI, amoxicillin, and clarithromycin. B. Proton pump inhibitor, PPI, and H receptor antagonists. C. Quadruple therapy with a PI, bimusubsalicylate, metronidazole, and tetracycline. D. Monotherapy with a proton pump inhibitor, PPI. Answer: A. Triple therapy with a proton pump inhibitor, PPI, amoxicillin, and clarithromycin. Explanation: Helicobacter pylori infection is a major cause of peptic ulcer disease, PUD. A most effective treatment regimen for eradicating H. pylori and healing ulcers is triple therapy, which includes a proton pump inhibitor, PPI, to reduce gastric acid production, and 2 antibiotics, amoxicillin and clarithromycin. Combination targets the bacteria and promotes healing of the ulcer. Option B, PPI and H receptor antagonists, would not be sufficient to eradicate H. pylori as it does not include antibiotics. Option C, quadruple therapy, is also effective, but triple therapy with PPI, amoxicillin, and clarithromycin is generally preferred as first-line treatment due to its simplicity and effectiveness. Option D, monotherapy with a PI, useful for reducing symptoms and healing the ulcer, but does not address the underlying H. pylori infection. Question 6. Mrs. Wilson, a 35-year-old female with Crohn's disease, is experiencing flare-up with increased abdominal pain, diarrhea, and weight loss. She is currently on melamine and corticosteroids, but her symptoms persist. What is the next step in management for her condition? A. Initiate biologic agent, such as infliximab. B. Increase the dose of corticosteroids. C. Discontinue mesalamine and start azathioprine. D. Recommend dietary changes, including low-fiber diet. Answer: A. Initiate a biologic agent, such as infliximab. Explanation: in Crohn's disease, when symptoms are not controlled with conventional therapy, mesalamine and corticosteroids, biologic agents such as infliximab, which is tumor necrosis factor (TNF) inhibitor, are often used. Biologics are effective in reducing inflammation and promoting remission in moderate to severe cases of Crohn's disease. Option B, increasing corticosteroid dosage, is generally avoided for long-term management due to the risk of side effects like osteoporosis, diabetes, and hypertension. Option C, switching to azathioprine, is another immunosuppressive treatment, but it is not typically the first choice when biologic agent could be used more effectively. Option D, dietary changes may help manage mild symptoms, but is unlikely to be sufficient in managing flare-up of Crohn's disease. Question 7. A 72-year-old male with a history of colorectal cancer is undergoing surveillance colonoscopy 3 years after his initial resection. During the procedure, a small, flat lesion is identified in the rectum. The lesion is biopsied and pathology confirms high-grade dysplasia. What is the next recommended course of action? A. No further intervention, as this is a benign finding. B. Surveillance colonoscopy every 6 months. C. Surgical resection of the lesion. D. Perform endoscopic mucosal resection, EMA. Answer: D. Perform endoscopic mucosal resection. EMA. Explanation: high-grade dysplasia in a patient with a history of colorectal cancer warrants endoscopic mucosal resection. EMA. A procedure in which the lesion is removed through endoscopy. This approach is preferred for lesions that are confined to the mucosa and have not invaded deeper layers, offering a minimally invasive option to prevent progression to cancer. Option Q. No further intervention is incorrect because high-grade dysplasia is a precancerous condition that requires intervention to prevent cancer development. Option B. Surveillance every 6 months would be insufficient as the lesion has already been identified as high-grade dysplasia. Option C. Surgical resection is an option but is more invasive and typically reserved for cases where endoscopic resection is not feasible or the lesion is larger or more advanced. Question 8. A 45-year-old male with a history of chronic hepatitis C presents with fatigue, jaundice, and elevated liver enzymes. He has a family history of liver cancer. Which of the following is the most important screening test for assessing his risk of hepatocellular carcinoma ACC? A. Liver biopsy. B. Alpha-fetoprotein blood test and ultrasound. C. CT scan of the abdomen. D. Magnetic resonance imaging MRI of the liver. Answer: B. Alpha-fetoprotein blood test and ultrasound. Explanation: in patients with chronic liver disease such as hepatitis C, screening for hepatocellular carcinoma ACC involves alpha-fetoprotein testing and ultrasound of the liver. AFP is a tumor marker that is elevated in many cases of HCC, and ultrasound is a non-invasive imaging modality that can detect liver masses. Option's liver biopsy is not routinely used for HCC screening as it is invasive and not required if imaging and AFP testing are sufficient. Option C, CT scan, and option D, MRI, may be used for further evaluation if the ultrasound suggests a lesion, but they are not first-line screening terfaci. Question 9. A 60-year-old male presents with a history of severe chest pain, shortness of breath, and diaphoresis. An electrocardiogram shows segment elevation in the anterior leads. What is the most likely diagnosis and what is the first-line treatment? A. Acute pericarditis, non-steroidal anti-inflammatory drugs, NSAIDs. B. Acute myocardial infarction by immediate administration of aspirin and nitroglycerin. C. Pulmonary embolism, anticoagulation therapy. D. Aortic dissection, surgical intervention. Answer: B. Acute myocardial infarction by immediate administration of aspirin and nitroglycerin. Explanation: the patient's presentation of severe chest pain, shortness of breath, diaphoresis, and segment elevation on ECG is highly suggestive of an acute myocardial infarction, particularly an anterior wall MI. The initial management involves aspirin to inhibit platelet aggregation and nitroglycerin to relieve pain and myocardial oxygen demand. Optical acute pericarditis would typically present with pleuritic chest pain and is not associated with segment elevation in the anterior leads. Option C, a pulmonary embolism would present with sudden onset dyspnea and pleuritic chest pain, but would not cause segment elevation. Option D, aortic dissection, is a possibility but would generally present with a tearing chest pain and may not show segment elevation on ECG. Question 10. A 28-year-old female with a history of systemic lupus erythematosus, SLE, presents with a malar rash, photosensitivity, and joint pain. Her laboratory results show a positive anti-nuclear antibody on and DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. SLE. C. Psoriatic arthritis. D. Dermatomyositis. Answer: B. Systemic lupus erythematosus, SLE. Explanation: the patient's presentation with a malar rash, photosensitivity, and positive anti-nuclear antibody on and DNA antibodies is highly suggestive of systemic lupus erythematosus, SLE, an autoimmune disorder that often affects young women. The hallmark features of SLE include a butterfly-shaped rash, joint pain, and specific autoantibodies like anti-DNA. Option was rheumatoid arthritis, typically presents with symmetric joint pain and morning stiffness, but lacks the specific skin manifestations and autoantibodies seen in SLE. Option C, psoriatic arthritis, is associated with psoriasis and joint pain, but it does not feature the hallmark of the malar rash or anadsna positivity. Option D, dermatomyositis, presents with a heliotrope rash and proximal muscle weakness, but lacks the systemic involvement and autoantibodies seen in SLE. Question 11. A 52-year-old female presents with a history of postmenopausal bleeding. On transvaginal ultrasound, an endometrial thickness of 5 millimeters is noted. What is the most appropriate next step in management? A. Endometrial biopsy. B. Hysteroscopy. C. Observation with repeat ultrasound in 6 months. D. Immediate dilation and curettage. DC. Answer A. Endometrial biopsy. Explanation: postmenopausal bleeding is a red flag symptom for endometrial pathology, such as endometrial hyperplasia or carcinoma. An endometrial biopsy is the most appropriate next step in evaluating the cause of bleeding. It allows for direct sampling of the endometrial tissue to assess for malignancy or precancerous changes. Option B, hysteroscopy, may be indicated if biopsy results are inconclusive or if further evaluation of the uterine cavity is required. Option C, observation, is not appropriate in a postmenopausal woman with bleeding as it could indicate significant pathology. Option D, dilation and curettage, is an invasive procedure that is not typically used as the first-line diagnostic tool for postmenopausal bleeding. Question 12. A 40-year-old male with a history of chronic hypertension presents with sudden onset severe headache, nausea and vomiting. His blood pressure is 220/138 G. Fundoscopic exam reveals papilledema. What is the most likely diagnosis and what is the first-line treatment? A. Hypertensive emergency, intravenous labetalol. B. Migraines or oral triptans. C. Subarachnoid hemorrhage. A. Canny of the head. D. Meningitis. Antibiotic therapy. Answer A. Hypertensive emergency, intravenous labetalol. Explanation: is patient with severely elevated blood pressure, 220/130 mmHg, headache, nausea, vomiting, and papilledema is most likely experiencing a hypertensive emergency which requires immediate management to lower blood pressure to prevent end organ damage. Intravenous labetalol is commonly used in such emergencies for its ability to reduce both systolic and diastolic blood pressure. Option B, migraines can present with headache and nausea, but the severity of the blood pressure and the presence of papilledema point more strongly to hypertensive emergency rather than a migraine. Option C, subarachnoid hemorrhage, could present with sudden onset headache, but the blood pressure alone is more indicative of a hypertensive crisis rather than a hemorrhage. Option D, meningitis, presence with fever, neck stiffness, and altered mental status, not primarily with hypertensive crisis. Question 13. A 58-year-old male with a history of alcohol abuse presents with confusion, ataxia, and ophthalmoplegia. He has a history of thiamine deficiency. What is the most likely diagnosis and what is the first-line treatment? A. Wernicke's encephalopathy, A. iamine. B. Korsakoff syndrome, oral thiamine. C. Alzheimer's disease, acetylcholinesterase inhibitors. D. Hepatic encephalopathy, lactulose. Answer A. Wernicke's encephalopathy, A. iamine. Explanation: the patient's symptoms of confusion, ataxia, and ophthalmoplegia in the context of chronic alcohol use suggest Wernicke's encephalopathy of thiamine, vitamin B deficiency syndrome. The most appropriate treatment iamine, which should be administered immediately to prevent further brain damage, as thiamine deficiency can cause irreversible brain damage if not treated early. Option B, Korsakoff syndrome, is a long-term complication of Wernicke's encephalopathy involving memory deficits, but this patient is presenting with acute symptoms. Option C, Alzheimer's disease, presents with progressive memory loss and cognitive decline, but not with the acute neurological signs seen here. Option D, hepatic encephalopathy, presents with confusion due to liver dysfunction but would not typically present with ataxia and ophthalmoplegia in this context. Question 14. A 35-year-old female presents with fatigue, weight gain, and constipation. On physical examination, she has dry skin, bradycardia, and cold intolerance. Her thyroid function tests show an elevated TH and low free T. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Adrenal insufficiency. D. Cushing's syndrome. Answer B. Hypothyroidism. Explanation: the patient's presentation with fatigue, weight gain, constipation, dry skin, bradycardia, and cold intolerance in the setting of elevated TH and low free T is consistent with hypothyroidism, a condition in which the thyroid gland produces insufficient thyroid hormones. Option was hypothyroidism, typically presents with symptoms like weight loss, increased heart rate, and heat intolerance, which are not present in this patient. Option C, adrenal insufficiency, presents with fatigue, weight loss, and hypotension, but the lab findings would differ, showing low cortisol levels rather than thyroid dysfunction. Option D, Cushing's syndrome typically causes weight gain and other symptoms due to excess cortisol, but the thyroid function tests in this patient are more indicative of hypothyroidism. Question 15. A 60-year-old male presents with severe chest pain radiating to his back, a tearing sensation, and a blood pressure difference between the arms. He is diagnosed with an aortic dissection. What is the initial management? A. Immediate intravenous beta blocker administration. B. Immediate administration of thrombolytics. C. Immediate surgical repair. D. Immediate anticoagulation therapy. Answer A. Immediate intravenous beta blocker administration. Explanation. In the case of an aortic dissection, the initial management focuses on reducing blood pressure and heart rate to decrease the stress on the aortic wall. The first-line treatment is the administration of an intravenous beta blocker, such as libitalol, to control the heart rate and lower systolic blood pressure. Option B. Thrombolytics are used for conditions like acute myocardial infarction or pulmonary embolism, not for aortic dissection. Option C. Surgical repair is typically indicated for type aortic dissections or complicated type B dissections, but initial medical management is crucial before surgery. Option D. Anticoagulation therapy is not indicated in aortic dissection and could worsen bleeding. Question 16. A 45-year-old female presents with symptoms of muscle weakness, fatigue, and ptosis. She has a history of difficulty swallowing and double vision that worsens at the end of the day. What is the most likely diagnosis? A. Myasthenia gravis. B. Guillain-Barré syndrome. C. Multiple sclerosis. D. Amyotrophic lateral sclerosis (ALS). Answer A. Myasthenia gravis. Explanation. The patient's muscle weakness, fatigue, ptosis, and worsening symptoms toward the end of the day are classic signs of myasthenia gravis, an autoimmune disorder characterized by antibodies against acetylcholine receptors, leading to impaired neuromuscular transmission. Option B. Guillain-Barré syndrome is progressive, descending paralysis that occurs after an infection, usually starting in the lower extremities. Option C. Multiple sclerosis typically presents with neurological deficits, including vision changes, weakness, and sensory disturbances, but it involves different patterns of demyelination and relapsus remissions. Option D. Amyotrophic lateral sclerosis presents with progressive motor weakness, but does not cause the ptosis or other ocular symptoms seen here. Question 17. A 25-year-old male presents with severe abdominal pain, fever, and leukocytosis. On examination, he has tenderness in the lower right quadrant. His history reveals that the pain started around the umbilicus before localizing to the right lower abdomen. What is the most likely diagnosis? A. Acute pancreatitis. B. Acute appendicitis. C. Gastroenteritis. D. Mesenteric ischemia. Answer B. Acute appendicitis. Explanation. The patient's severe abdominal pain, fever, leukocytosis, and localized tenderness in the right lower quadrant are suggestive of acute appendicitis, a common condition due to inflammation of the appendix. The typical pattern of pain starting near the umbilicus and then localizing to the right lower abdomen is characteristic. Optional acute pancreatitis typically presents with epigastric pain that radiates to the back, not localized to the right lower quadrant. Option C. Gastroenteritis can cause abdominal pain, but it is usually associated with diarrhea and vomiting, and it does not present with localized tenderness. Option D. Mesenteric ischemia usually presents with severe abdominal pain and may involve a history of atrial fibrillation, but it does not typically cause localized right lower quadrant pain. Question 18. A 70-year-old male with a history of chronic alcohol use presents with tremors, confusion, and visual hallucinations. His symptoms began 48 hours after he was admitted to the hospital for pneumonia. What is the most likely diagnosis and what is the first-line treatment? A. Alcohol withdrawal delirium, DT of benzodiazepines. B. Delirium due to infection and antibiotics. C. Wernicke-Korsakoff syndrome, thiamine supplementation. D. Acute psychosis, antipsychotics. Answer A. Alcohol withdrawal delirium, DT of benzodiazepines. Explanation. The patient's symptoms of tremors, confusion, and visual hallucinations occurring 48 hours after cessation of alcohol use are indicative of alcohol withdrawal delirium. Delirium tremens, a life-threatening condition. The first-line treatment involves the use of benzodiazepines, such as lorazepam or diazepam, to prevent seizures and manage agitation. Option B, delirium due to infection, is possible but less likely given the timing of symptoms after alcohol cessation. Option C, Wernicke-Korsakoff syndrome, presents with confusion, ataxia, and ophthalmoplegia, but it is not typically associated with hallucinations. Option D, acute psychosis is less likely in this context without other triggers or underlying psychiatric conditions. Question 19. A 55-year-old male presents with a persistent cough, hemoptysis, and weight loss over the past 2 months. He has a history of smoking and works in a factory with exposure to asbestos. On chest X-ray, there is a pleural effusion. What is the most likely diagnosis? A. Tuberculosis. B. Non-small cell lung cancer. C. Pneumonia. D. Mesothelioma. Answer: D. Mesothelioma. Explanation: the patient's persistent cough, hemoptysis, weight loss, and history of asbestos exposure point towards mesothelioma, rare malignancy associated with asbestos exposure. The pleural effusion seen on chest X-ray is also characteristic finding of mesothelioma. Option: tuberculosis can cause cough and weight loss, but it is typically associated with night sweats and history of contact with infected individuals, which are not present here. Option B, non-small cell lung cancer can present with similar symptoms, but mesothelioma is more likely given the asbestos exposure and pleural effusion. Option C, pneumonia, would typically present with fever, productive cough, and signs of infection, which are not consistent with this case. Question 20. A 32-year-old female presents with a butterfly-shaped rash across her nose and cheeks, joint pain, and photosensitivity. Her lab results show positive anti-nuclear antibodies on and anti-DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Dermatomyositis. D. Sjogren's syndrome. Answer: B. Systemic lupus erythematosus. Explanation: the butterfly-shaped rash, joint pain, photosensitivity, and positive on and DNA antibodies are characteristic of systemic lupus erythematosus, SLE, a chronic autoimmune disease that can affect multiple organ systems. Option's rheumatoid arthritis typically presents with symmetrical joint pain, particularly in the hands and wrists, and does not cause a butterfly rash or positive anti-DNA. Option C, dermatomyositis, can cause a rash and muscle weakness, but it typically presents with a heliotrope rash around the eyes and is associated with muscle involvement. Option D, Sjogren's syndrome, is characterized by dry eyes and mouth, and a positive on it is common but does not cause butterfly rash. Question 21. A 45-year-old female with a history of depression and diabetes presents with a new onset of manic symptoms, including increased energy, racing thoughts, and decreased need for sleep. She also reports engaging in impulsive spending. What is the most likely diagnosis? A. Bipolar disorder. B. Major depressive disorder. C. Generalized anxiety disorder. D. Schizophrenia. Answer A. Bipolar disorder. Explanation: the patient's manic symptoms, including increased energy, racing thoughts, decreased need for sleep, and impulsive behavior in the context of history of depression, are characteristic of bipolar disorder. Specifically, this presentation suggests manic episode in patient with history of depression. Option B, major depressive disorder, would present with low mood, fatigue, and other depressive symptoms, not manic symptoms. Option C, generalized anxiety disorder, typically presents with excessive worry, but it does not include manic symptoms. Option D, schizophrenia, involves psychotic symptoms such as delusions or hallucinations, which are not present in this case. Question 22. A 65-year-old male with a history of hypertension and hyperlipidemia presents with sudden onset weakness in his right arm and leg along with difficulty speaking. His symptoms began 30 minutes ago. On examination, he has right-sided hemiparesis and expressive aphasia. What is the most likely diagnosis? A. Transient ischemic attack. B. Acute myocardial infarction. C. Stroke. D. Seizure. Answer: C. Stroke. Explanation: the patient's sudden onset weakness, right-sided hemiparesis, and expressive aphasia are characteristic of a stroke, specifically an ischemic stroke affecting the left hemisphere of the brain. The rapid onset of symptoms suggests a non-transient event. Optional transient ischemic attack typically presents with symptoms similar to a stroke but lasts for a shorter duration, minutes to hours, and resolves completely. Option B, acute myocardial infarction, presents with chest pain, shortness of breath, and possibly diaphoresis, not with neurological deficits. Option D, seizure, can cause postictal weakness, but would not explain the sudden and focal nature of the symptoms or the language disturbance. Question 23. A 40-year-old female presents with diffuse muscle weakness, difficulty swallowing, and dry mouth. On examination, she has decreased reflexes and no sensory deficits as symptoms improve with rest. What is the most likely diagnosis? A. Myasthenia gravis. B. Guillain-Barré syndrome. C. Lambert-Eaton syndrome. D. Multiple sclerosis. Answer: C. Lambert-Eaton syndrome. Explanation: the patient's muscle weakness, difficulty swallowing, and dry mouth, along with improvement with rest, are characteristic of Lambert-Eaton syndrome, an autoimmune disorder that affects the presynaptic voltage-gated calcium channels at the neuromuscular junction, often present with proximal muscle weakness and autonomic symptoms like dry mouth. Option: myasthenia gravis causes weakness that worsens with activity, not improves with rest. Option B, Guillain-Barré syndrome, typically causes ascending motor weakness and does not present with dry mouth or improve with rest. Option D, multiple sclerosis is central nervous system demyelinating disorder that causes motor and sensory deficits but does not typically present with dry mouth or improve with rest. Question 24. A 68-year-old male with a history of hypertension and smoking presents with sudden onset of severe chest pain that radiates to his back. He is diaphoretic and appears anxious. On examination, his blood pressure is 90/60 mmHg and he has a heart rate of 110 EM. A chest X-ray shows widening of the mediastinum. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Pericarditis. Answer: B. Aortic dissection. Explanation: the patient's sudden severe chest pain radiating to the back, hypotension, tachycardia, and widened mediastinum on chest X-ray are highly suggestive of an aortic dissection, which occurs when there is tear in the aortic wall, causing blood to flow between the layers of the vessel wall. Option: acute myocardial infarction, typically presents with chest pain, but does not cause the sudden onset of pain radiating to the back or widened mediastinum. Option C, pulmonary embolism, would present with sharp pleuritic chest pain, shortness of breath, and possibly hypoxia, not widened mediastinum. Option D, pericarditis, presents with pleuritic chest pain and is associated with pericardial friction rod but does not cause mediastinal widening. Question 25. A 72-year-old female with a history of osteoarthritis presents with new onset pain in her right hip, which is worse with movement. She also complains of feeling more fatigued and having a loss of appetite over the past month. On examination, she has tenderness over the hip joint and a limited range of motion. An X-ray shows an ill-defined area of bone destruction. What is the most likely diagnosis? A. Osteoarthritis. B. Hip fracture. C. Osteomyelitis. D. Primary bone cancer. Answer: C. Osteomyelitis. Explanation: the patient's hip pain, fatigue, loss of appetite, and bone destruction on X-ray suggest osteomyelitis, which is an infection of the bone. The symptoms of fatigue and appetite loss, along with bone destruction, are key indicators of an infectious process. Option: osteoarthritis is typically associated with joint pain but does not cause bone destruction or systemic symptoms like fatigue and loss of appetite. Option B, hip fracture presents with acute pain and limited mobility, but it would not show the ill-defined bone destruction seen in this case. Option D, primary bone cancer can cause bone pain and destruction, but usually affects younger patients and does not have the same systemic symptoms as osteomyelitis. Question 26. A 25-year-old male presents with painful, swollen joints in his knees, ankles, and wrists. He has a history of urethritis that occurred 3 weeks ago. On examination, he has conjunctivitis and lesions on his palms and soles. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Reactive arthritis. C. Systemic lupus erythematosus. D. Psoriatic arthritis. Answer: B. Reactive arthritis. Explanation: the patient's symptoms of painful swollen joints, history of urethritis, conjunctivitis, and lesions on palms and soles are classic signs of reactive arthritis, formerly known as Reiter's syndrome, which is an autoimmune response following bacterial infections such as chlamydia or gastrointestinal infections. Option: rheumatoid arthritis is chronic autoimmune disease that primarily affects the small joints of the hands and feet and does not cause the systemic symptoms, urethritis, conjunctivitis, seen here. Option C, systemic lupus erythematosus, typically present with butterfly-shaped rash, photosensitivity, and systemic involvement, but not with history of urethritis. Option D, psoriatic arthritis, is associated with psoriasis and can cause joint pain, but it is not typically associated with urethritis or conjunctivitis. Question 27. A 40-year-old male presents with fatigue, weight gain, and cold intolerance. On examination, he has dry skin, bradycardia, and a delayed relaxation phase of his deep tendon reflexes. His TSH is elevated and Freed is low. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Adrenal insufficiency. D. Depression. Answer: B. Hypothyroidism. Explanation: the patient's fatigue, weight gain, cold intolerance, dry skin, bradycardia, and delayed reflexes, along with elevated TH and low free T, are consistent with hypothyroidism, condition in which the thyroid gland produces insufficient thyroid hormone. Optioned: hypothyroidism, typically presents with symptoms such as weight loss, heat intolerance, and tachycardia, which are the opposite of the patient's presentation. Option C: adrenal insufficiency can cause fatigue and weight loss, but does not explain the thyroid profile and delayed reflexes. Option D: depression can cause fatigue and weight gain, but would not account for the elevated TH and load levels. Question 20. A 55-year-old female with a history of asthma presents with sudden onset shortness of breath, wheezing, and chest tightness after being exposed to a known allergen. She is using her albuterol inhaler more frequently with little relief. What is the most appropriate next step in management? A. Increase the frequency of albuterol inhaler use. B. Administer oral corticosteroids. C. Start an oral bronchodilator. D. Order a chest X-ray. Answer: B. Administer oral corticosteroids. Explanation: the patient's symptoms of sudden onset shortness of breath, wheezing, and chest tightness in the context of asthma and ineffective use of an inhaler indicate moderate to severe asthma exacerbation. Oral corticosteroids are the standard treatment for exacerbations to reduce inflammation and improve airflow. Option: increase the frequency of albuterol inhaler use is not sufficient in managing moderate to severe exacerbation and could lead to overuse of short-acting bronchodilators. Option C: start an oral bronchodilator is not the most appropriate next step in acute management. Corticosteroids are more effective. Option D: order chest X-ray is not necessary unless there is concern for differential diagnosis, such as pneumonia or pneumothorax. Question 29. A 60-year-old male with a history of smoking presents with a persistent cough, weight loss, and hemoptysis. The chest CT scan reveals a mass in the left lung with associated lymphadenopathy. What is the most likely diagnosis? A. Pneumonia. B. Tuberculosis. C. Lung cancer. D. Pulmonary embolism. Answer: C. Lung cancer. Explanation: the patient's persistent cough, weight loss, hemoptysis, and lung mass with lymphadenopathy are classic signs of lung cancer, particularly non-small cell lung cancer, which is common in smokers. Option: pneumonia would present with acute symptoms, fever, and often consolidation on imaging, but it would not cause mass or lymphadenopathy. Option B: tuberculosis can present with weight loss and hemoptysis, but the chest CT findings of mass are more consistent with cancer. Option D: pulmonary embolism can cause hemoptysis and shortness of breath, but it would not typically cause mass or weight loss. Question 30. A 32-year-old female presents with a 6-month history of excessive thirst, frequent urination, and weight loss despite a normal appetite. On examination, she has dry mucous membranes and her blood glucose is 350 mg/dL. What is the most likely diagnosis? A. Diabetes insipidus. B. Type 1 diabetes mellitus. C. Type 2 diabetes mellitus. D. Hypothyroidism. Answer: B. Type 1 diabetes mellitus. Explanation: the patient's symptoms of excessive thirst, frequent urination, and weight loss in the context of hypoglycemia are characteristic of type 1 diabetes mellitus, an autoimmune disorder that typically presents in younger individuals with insulin deficiency. Option: diabetes insipidus causes polyuria and polydipsia, but is due to deficiency in antidiuretic hormone, not elevated blood glucose levels. Option C: type 2 diabetes mellitus typically presents in older individuals and is usually associated with obesity, though it can present with similar symptoms. Option D: hypothyroidism can cause weight loss and increased thirst, but it does not typically cause hypoglycemia.